starting back in 1950s with the original work of Heads and Endless, when by only having an M-mode, they were trying to make the diagnosis of rheumatic mitral valve disease, and especially with the introduction of the 2D echocardiography and color flow Doppler, now it is possible to diagnose most of the congenital heart defects. Here you can see a remembrance VSD in a short axis view. We can assess the size of the defects from different views, the short axis, the apical view. We can assess and estimate the loading of the left ventricle using M-mode. And actually, by having a Doppler, we can assess the pressure difference between the RV and LV. However, the need for a more detailed and accurate anatomic and functional information has led to the development of what we call now modern echocardiographic techniques. These involve the three-dimensional echocardiography, tissue Doppler, spectral tracking, and novel methods like the 4D flow, and I will try to give you an overview about these techniques. We all know that the heart is a 3D structure, so it is reasonable to understand that by using actually 2D imaging modalities to visualize the heart, we may lack critical spatial information. Some structures may move in and out of plane, and actually, when we have the 2D images, we always need an interpreter, because what we see is completely different to what the surgeons will see in the operating room. In the last 20 years, there have been significant advances in 3D echocardiography, and currently is being used as an adjunct to 2D echocardiography. Starting from the first attempts here to have a 3D model of the heart using a mechanical spatial locator, we have significant advances in transducer technology. Now we can use matrix array probes with small footprints that actually can be used in children, and also we have rapid computer processing. We can have very good image quality and actually very good time and rapid analysis. And we can actually even follow the cardiac anatomy in real time, assess the cardiac function, and also the hemodynamics. But when actually 3D echocardiography is more useful and can give us additional information to 2D, it is very important to assess accurately the size and the position of septal defects. It can give us improved information about the morphology of the AV valves and also the areas of non-coaptation. We can see the relationship of the different structures and actually can help us decide about the surgical planning of complex congenital heart defects. We can visualize the wires and devices very well, and sometimes can be really, really helpful for complex catheter cases. And of course, functional assessment has been one of the main uses of the 3D echocardiography. And here you can see some examples. This is a nice clip of a full picture of the atrial septum, as this is visualized from the right atrial aspect. We can understand the surrounding structures, the mouth of the HVC and IVC. We can see the oval fossa and the defect in the middle. But apart from the anatomy, we can do accurate measurements. Using Zoom 3D and MPR format, we can measure the minimum and maximum dimensions of the ASD. Although we cannot really argue that for every interventional closure of the ASD we need a 3D echocardiography, it can be particularly helpful for complex cases like this one. In this case, using live 3D, you can see that we have a device already there, and there is a residual defect. Now we can follow the delivery catheter, and then we can see how the device can be introduced from the right and the left atrial side, and in the end, because we know that actually the atrial septum is not a flat surface, we can understand and see in one projection the configuration of the one device versus the other. Now, apart from the ASDs, VSDs can also very well visualize using 3D echocardiography. This is a nice picture from a patient in our unit with transposition of the great arteries that had multiple VSDs. The inlet VSD here, if seen only from the four-chamber view, possibly we would say that it has a slit-like appearance and might consider to be quite small. But having 3D echocardiography, we can have exact dimensions, we can see the shape of the defect, and we can do better assessment. If, for example, in cases where we need to undertake interventional closure of the VSD, then the assessment of the rims around the defect can also very well be seen with 3D echocardiography. Here you can see the rims of the defect. We can measure the distance from the aortic valve and also from the tricuspid valve, So when we want to insert the device, we can estimate whether we are going to damage the aortic valve and the tricuspid valve. Of course, the adequacy of the rims will depend on the size of the defect, but also on the type of the device that we want to deploy. This is another example of a double-committed subarterial VSD, which is partially covered by aortic cusp prolapse. And by using an NPR format, which you can see on this side, we can actually interrogate the different leaflets of the aortic valve and identify that actually the right coronary cusp is the one that is prolapsing into the defect. The understanding of the AV valve morphology has significantly improved with 3D echocardiography. Here you can see an anterior cleft mitral valve on the right-hand side and left AV valve of an AVSD on the left-hand side. You can appreciate that the cleft on the first picture is directed towards the left ventricular outflow tract, whereas in the second case it's directed towards the septum. Now, by the NPR format in a patient with a prolapse of the mitral valve, again we can interrogate the different leaflets of the mitral valve, and we can identify in this case that the A2 cusp of the mitral valve is the one that is prolapsing and is creating the regurgitation. By doing appropriate cropping of the 3D rendered volume, we can assess the chordal attachments of the AV valve and also the whole supporting apparatus of the AV valve. In the first picture, you can appreciate that there are chordal attachments from the tricuspid valve, that they're crossing the ventricular septum, and they are attached to the papillary muscle of the mitral valve. In the second case, we can see that the chordal attachments of the mitral valve, they are attached to a single papillary muscle compared to the medial and the lateral one in the normal situation, and this will make the defining diagnosis of a parachute mitral valve. Now, in our department, we think that 3D echocardiography is particularly useful when we need and to design surgical planning for complex cases like this one, where we have a double outlet right ventricle. Using 3D echocardiography, we can have in one view the relationship of the different structures. We can see the mitral valve, the tricuspid valve, the aorta, and the pulmonary artery, and the pulmonary valve. So then we can estimate and actually plan that if we want to baffle the left ventricle to the aorta, whether we're going to obstruct the tricuspid valve inflow to the RV, or actually the RV outflow to the pulmonary artery. So in cases like this one, where we have a double outlet right ventricle with subpulmonary VSD, we feel that by baffling the LV to the aorta, actually we are going to obstruct the tricuspid valve inflow. So then an arterial switch operation will be the appropriate one to make easy the access from the LV to the aorta. Adequacy of the VSD in double outlet right ventricle, we are used to assess the actual size of the VSD, and we use these NPR and rendered views, and we compare the size of the VSD compared to the size of the aortic valve annulus for a child of a similar age. Now, moving on from the anatomy, assessment and regular assessment of the cardiac function in congenital heart disease patients has been one of the main aspects of the long-term follow-up. So far, using conventional echocardiography, we're used to assess systolic function by quantifying changes in ventricular dimensions and chamber volume, and diastolic function by having Doppler-derived blood flow velocities across the AV valves. However, now we have new opportunities, most of them currently being used in research practice, but we can use them and start using them in clinical practice as well, can give us direct information about functional properties of LV and RV. We all know what is happening in the heart during the cardiac cycle. So the heart generates force, and this force is transmitted through the myocardial fibers, and then into the cavity, and when the pressure goes up, then the semilunar valves open up and we have the ejection. Then the heart relaxes, and then we have the filling of the ventricle in diastole. Now, in order to have the appropriate transmission of the force, we need several parameters to work properly. This is the geometry of the ventricle. We know that the left ventricle has an ellipsoid appearance, whilst the right ventricle has a crescent shape. This reflects the different hemodynamics and the different pressures in the two ventricles. The fiber orientation is different, and actually we can achieve 60% ejection fraction in the LV by only having 15% fiber shortening. It is very important for an appropriate ejection to have synchronous deformation of the different myocardial segments, and the wall elasticity is also very important. Now, in congenital heart disease patients, all of these things, any of these parameters can go wrong. Now, we have different methods to assess different parameters into the functional assessment of the LV and RV, and most of them actually they have been validated for the LV. However, I'm not going to go into detail for the LV functional assessment, as this is the next topic for the next talk. And I will try to give you some information about the RV functional assessment, which has been really challenging. So far, we used to use different modalities, from the really qualitative one, like the eyeballing, to assess whether the RV is working properly, then the TAPSI to do the longitudinal function, TI index, and then we have more advanced techniques, the tissue Doppler, the strain, and the 3D echocardiography. Now, TAPSI is the one that is most commonly used. We have an mode line across the lateral wall of the RV, and we're measuring the total displacement of the tricuspid annulus excursion and the timing of the displacement. This technique is very reproducible and sensitive, but we must not forget that actually it's load and angle dependent. We now have normal values that actually we can apply even in children, so the TAPSI can range from 0.9 in neonates up to 2.47 in an 18-year-old adolescent. But as far as more advanced techniques, tissue Doppler is one of those. So we can assess myocardial systolic and diastolic velocities. This is a nice study published by Vitarelli et al. A long time ago in 2005. In a small group of Fontan patients, they tried to assess longitudinally the tissue Doppler in a single RV. They have identified that the myocardial systolic velocities, they are reduced compared to controls, but they were able to demonstrate that actually the S velocity and the S measurement, they correlate quite well with the ejection fraction that we can calculate from the echocardiography. And values above 7 centimeters per second actually relate to what we call a normal ejection fraction. Again, this technique is angle dependent and is affected by the heart motion and cardiac rotation. We have now more novel techniques, and one of those is speckle tracking. So this technique has been introduced mostly and is currently used in research for research purposes. It is angle independent and is thought to be less preload dependent compared to tissue Doppler. What the technique does is identify areas of the myocardium, what we call kernels, and we follow them through the cardiac cycle. So then we can assess the global deformation of the ventricle, but also the regional deformation. And we have measurements like the strain, which is the percentage change in the length of the myocardial segment. We have the strain rate, which is the rate of change in the deformation, but also we can measure the timing of the deformation. This is a nice study published in 2014, where they used speckle tracking to the long-term follow-up of patients with univentricular heart as they were going through the different stages of palliation. What was interesting about using the speckle tracking was actually that the RV was adapting, from the Norwood 1 to Norwood 2 and ultimately the Fontan, so that the contraction pattern of the RV ventricle was changing to mimic the LV ventricle. Now, there was a decline in the longitudinal deformation, which is commonly seen in the RV, and an increase in the circumferential deformation. And the lack of this decline actually was associated with the failure of adaptation and poor ventricular function. Using speckle tracking as well, we can assess the time to peak systolic strain, which actually gives us an estimate of mechanical desynchrony. This is very important because when we identify mechanical desynchrony, especially in patients like the Fontans or the tetralogy of Fallot patients who have been exposed to chronic overload from pulmonary regurgitation, actually we can help and have better ejection by having CRT treatment. By doing that, we can achieve rapid and uniform ventricular depolarization. Now, 3D echocardiography has also been suggested as another method in order to assess RV function. However, assessment of RV function has been quite challenging with this method. The reason is actually that the RV does not really conform to any usual geometric model, And when we have to manually draw the endocardial contour, this can be very difficult, especially for the anterior segment and the right ventricular outflow tract, because it might not be possible to be seen. So by doing this manually contour, we can create a 3D dynamic surface model. We can extrapolate the global volume time curve, and then we can have the global ejection fraction and the end diastolic volumes and end systolic volumes, like the same process that we could have with the MRI. The question is, however, how accurate is these measurements? Now, a number of different groups, including ours, they have tried to see the agreement between the functional assessment that we perform with 3D echocardiography and the gold standard, which is the MRI. And actually, the agreement was not very good. 3D echocardiography appears that underestimates the RV volumes and the RV ejection fraction, and the error that we get in the measurement is actually bigger when we have larger volumes. Now, there are novel ways that we can assess RV function. This is a study published from the Toronto group, from Andrea Geratulescu, where actually by using a knowledge-based reconstruction of the RV, they use tract probe and multiple cross-section images in order to generate a 3D volume of the heart, using as a reference a database of normal and abnormal values. So in practice, what we're doing, we identify structures in the RV and we select points. And by doing that, then the computer automatically creates the border and creates the volume of the RV. Now, when they tested the agreement between this method and the MRI, actually the agreement was better than the 3D echocardiography. Now, it is just recently that in research practice we have new information to suggest that we can detect early functional changes by measuring intracavity flow and vortex formation, because these can have an impact on ventricular efficiency and energy loss. In this diagram, you can appreciate the differences in the flow during the ventricular remodeling. So when we have in the first picture here a healthy ventricle with normal filling and normal emptying, then there is regular flow, there's no turbulence, and we have what we call here a stable situation. In cases where we start having an impaired flow, which we think that this is the primary thing, then rather than having only longitudinal intra-cavity pressures, we also have transverse intracavity pressures. We start having turbulence inside the ventricle, and the ventricle will adapt to this stimulus by having ventricular stiffening. Then we are getting into a vicious cycle. So the ventricular stiffening will induce further turbulence into the flow, and then the ventricle will respond with progressive adaptation, which ultimately will result in dilated ventricle with reduced systolic function, and then we call it a metastable situation that actually we don't have too many opportunities for further adaptation. Now, this is only in the research field, and this is data from our department. One of our imaging fellows, Alberto Gomez, has managed to publish and actually to create a method where he can estimate intracavity flow by using 3D time resolved velocity vectors, by using a combination of multiple 3D color Doppler images and wall motion data from 3D mode. And by using this Multiview 3D echo approach, actually he was able to demonstrate that he could get very good agreement with MRI. Now, the benefit for doing this is actually for small children. If we think that this flow assessment will be as accurate as MRI, then we don't need to have the general anesthesia, and then we can have better quantification of all the congenital heart disease problems. Now, one of the issues with 3D echocardiography, of course, has been the technology that we use in order to display 3D images. Because it's all very nice, we have the 3D images, but actually we keep displaying them on a conventional flat screens, which actually it's a 2D projection. And we're trying to use different tricks, like color coding, to give us the perception of the depth. But now we have the opportunity to create heart-specific model from different conditions. This is a patient with a double arcuate right ventricle, and we have printed a model of the heart. And this can be particularly helpful for training purposes, but also, for surgical planning. This is really attractive area, but of course there are limitations, because by the time that you produce this printout, you cannot crop it any further, and actually it reflects only one part of the cardiac cycle. So we cannot really assess dynamic changes in the valves. So in summary, I hope that I have convinced you that we are facing an exciting time in echocardiography. We have a number of modern techniques that we can use in order to assess accurate the cardiac anatomy, the function, and also the hemodynamics. Of course, most of them are still used in research purposes, but hopefully with better standardization, increased automation, and improved volumetric and flow quantification, the clinical use will not be far. Now, we have the development of other new modeling techniques. In our department, we have instigated the holography, but I cannot really show you any images as yet, which we can use for education and for surgical planning. Finally, I would like to thank the whole team at the Evelina Children's Hospital, my colleagues, the imaging consultants, the imaging fellow, and especially Alberto Gomez for all his work in the intracavity flow, and the cardiac physiology team for the collection of all these nice images. Thank you for your attention.